Welcome to our video on non-Hodgkin lymphomas. Let's begin. These are the topics we will cover for non-Hodgkin's lymphoma. Let's start by discussing epidemiology. Non-Hodgkin lymphoma is a diverse group of solid tumors. It's twice as common as Hodgkin's disease, and patients with non-Hodgkin lymphoma tend to have more advanced disease at presentation than patients with Hodgkin disease. The mean age of onset varies with the subtype, but there is an increased overall incidence with increasing age. Lymphomas subdivide in low, intermediate, and high-grade lymphomas. There are also some miscellaneous lymphomas. The type of lymphocyte involved and its level of differentiation determines the course of the disease and its prognosis. There are many subtypes of non-Hodgkin lymphoma, so as we go through this portion of the lecture, we will focus on the subtypes most high yield for step 2. Non-Hodgkin lymphomas occur due to the malignant transformation and growth of B or T lymphocytes, or their precursors, in the lymphatic system. B-cell lymphomas account for 85% of all cases, while T-cell lymphomas account for 15% of all cases. The disease usually starts in lymph nodes and may spread to blood and bone marrow. The risk factors are very important and may show up in clinical vignettes on your board exams. One main risk factor is a compromised immune system, which includes patients with HIV/AIDS and patients with immunosuppression, such as in organ transplant recipients. Patients with a history of certain viral infections like EBV or HTLV1 are also higher risk of non-Hodgkin lymphoma. Patients with a history of Helicobacter pylori gastritis are at risk of gastric lymphoma, and patients with autoimmune diseases like Hashimoto thyroiditis or Sjogren's syndrome are at risk of mucosa-associated lymphoid tissue lymphomas. Now we will look at these tables to help us recognize the high-yield information in relation to non-Hodgkin lymphomas. There are more than 20 different subtypes of non-Hodgkin lymphoma, arranged into several unique classification systems. One such classification system stratifies subtypes according to histological grade, which includes low-grade or indolent, intermediate grade, and high-grade, which is in the table on the next slide. We will discuss two types of low-grade lymphoma: small lymphocytic lymphoma and follicular lymphoma. The small lymphocytic lymphoma is closely related to chronic lymphocytic leukemia, and it is more common in elderly patients. It has an indolent course, meaning it causes little or no pain. This type eventually will result in dissemination to liver, spleen, and bone marrow. Follicular lymphoma is the most common form of non-Hodgkin lymphoma. It has a mean age of onset of 55 years old and may transform into diffuse large cell lymphoma. It is associated with the translocation T14 and 18. It also has an indolent course and presents with painless peripheral lymphadenopathy. The prognosis of localized disease is good, with most patients being able to be cured with radiotherapy. However, the median survival of non-Hodgkin lymphoma is 10 years. Here is a histologic image of small lymphocytic lymphoma. This histology shows pseudofollicles composed of mature lymphocytes in peripheral blood. The cells are CD5 and CD23. Now let's discuss an intermediate grade lymphoma, diffuse large cell lymphoma. Diffuse large cell lymphoma is mostly B-cell origin. It is most commonly seen in middle-aged and elderly patients and is locally invasive and presents as large extranodal mass. There is an 85% cure rate with CHOP therapy, which we will discuss in the treatment section of this lecture. Here is an image of diffuse large cell lymphoma. Notice the large B lymphoid cells. The nuclei of these B cells are at least twice the size of the surrounding lymphocytes. Now let's discuss some of the high-grade lymphomas. Lymphoblastic lymphoma is a T-cell lymphoma that is more common in children and can progress to T-cell and acute lymphocytic leukemia. It is commonly associated with B symptoms at diagnosis, such as fatigue or night sweats. It is considered aggressive with rapid dissemination, and it may respond to chemotherapy. Another high-grade lymphoma is Burkitt lymphoma, which is a B-cell lymphoma. It is also more common in children. There are two types: the African or endemic variant and the sporadic variant. The African variant most commonly involves the maxilla or jaw, whereas the sporadic variant involves abdominal organs. The African variant is linked to Epstein-Barr virus infection. Burkitt lymphoma is often associated with chromosomal translocation between chromosomes 8 and 14, and often has a poor prognosis if it is not aggressively treated with chemotherapy. Let's take a look at the histology of Burkitt lymphoma. In this lymphoma, the normal lymph node architecture is entirely replaced by lymphoma cells and evenly dispersed macrophages, giving it the commonly called starry sky appearance. Involved tissues are effaced by a diffuse infiltrate of monomorphic medium-sized nuclei, similar or smaller to those of histiocytes and transformed lymphoid cells. The cytoplasm is deeply basophilic, which is why the color is so vivid and usually contains lipid vacuoles. Lastly, a high mitotic index is typical, as is apoptotic tumor cell death, accounting for the presence of numerous tissue macrophages with their ingested tissue debris. Now we will discuss one other miscellaneous lymphoma, mycosis fungoides. Mycosis fungoides is a T-cell lymphoma of the skin that presents with eczematous skin lesions that may progress to generalized erythroderma. One unique characteristic of mycosis fungoides is that the lymphocytes seen on histology have a cribriform shape, which means they have holes like Swiss cheese. The prognosis of this lymphoma is dependent on the degree of dissemination, but it is potentially curable with radiation and topical chemotherapy if it is limited to the skin. Let's take a look at the histology of mycosis fungoides. Here are infiltrates of malignant T cells. These are small to medium in size and characteristically have irregular cerebriform nuclei. Before we move on to a review question, now would be a great time to pause the lecture and review the tables that we just covered, as they contain a lot of information. Let's look at a question now. What are the differences between the endemic and sporadic variants of Burkitt lymphoma? Is it a B or T cell lymphoma? There are two variants of Burkitt lymphoma, the African or endemic variant and the sporadic variant. The African variant most commonly involves the maxilla or jaw, whereas the American variant involves abdominal organs. The African variant is more commonly linked to Epstein-Barr virus infection than the sporadic forms. Now, is this a B or T cell lymphoma? Recall that Burkitt is one of the high grades of non-Hodgkin lymphomas, along with the lymphoblastic lymphoma. Burkitt is a B-cell lymphoma, while lymphoblastic lymphoma is a T-cell lymphoma. Now let's discuss the diagnosis of non-Hodgkin lymphomas. The initial step in diagnosis of a Hodgkin lymphoma is lymph node biopsy. Any lymph node greater than 1 centimeter presents for more than 4 weeks that cannot be attributed to infection should be biopsied. Chest X-ray and CT scan of chest, abdomen, or pelvis can be used to examine further lymph node involvement. Bone marrow biopsy may reveal bone marrow involvement. An elevated alkaline phosphatase is seen if there is bone or liver involvement. Elevated liver function tests or bilirubin may be present if there is liver involvement. A complete blood count with anemia, leukopenia, or thrombocytopenia may be present if there is bone marrow involvement. The treatment for non-Hodgkin lymphoma varies depending on the stage and subtype. The indolent or low-grade forms of non-Hodgkin lymphomas are rarely curable but have a 5-year survival rate of 75%. These patients are treated in a variety of ways, including observation, chemotherapy, and radiation therapy. Intermediate and high-grade non-Hodgkin lymphoma may be curable with aggressive treatments, but if complete remission is not achieved, survival is usually less than 2 years. In general, high-grade lymphomas, because of their aggressiveness, are treated with multiple regimens of combination chemotherapy and radiation therapy. There are 4 commonly used medications that can be remembered with the mnemonic CHOP, which stands for cyclophosphamide, hydroxydonomycin, also known as doxorubicin, oncovin, also known as vincristine, and prednisone. Rituximab, a monoclonal antibody against CD20 antigen, is often used in combination with CHOP therapy to treat non-Hodgkin lymphoma and other cancers with better outcomes than CHOP alone. Some patients may benefit from high-dose chemotherapy with bone marrow transplantation. Okay, let's finish out this lecture with some practice questions. An oncologist prescribes cyclophosphamide, doxorubicin, vincristine, and prednisone for the treatment of a patient with a new lymphoma diagnosis. Is the patient's pathology more likely Hodgkin's lymphoma or non-Hodgkin's lymphoma? These are the 4 most commonly used medications for non-Hodgkin lymphoma: cyclophosphamide, hydroxydonomycin, also known as doxorubicin, oncovin, also known as vincristine, and prednisone, make up the combination CHOP, chemotherapy regimen used in intermediate and high-grade non-Hodgkin lymphomas. A 9-year-old boy is brought to the physician due to intermittent vomiting and unintentional 12-kilogram weight loss over the past 6 months. He has past medical history of Epstein-Barr virus infection. He was born at term without any perinatal or postnatal complications. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 80/60, heart rate of 91, and a respiratory rate of 15. Physical exam reveals sunken eyes, decreased skin turgor, and hepatosplenomegaly. Stool culture, ova and parasite test, and fecal fat studies are negative. The abdominal ultrasound reveals a hypoechoic mass in the duodenal wall. Biopsy of the mass shows small basophilic cells and evenly dispersed macrophages, leading to the starry sky appearance. Which of the following is the most likely diagnosis in this patient? A. Hodgkin lymphoma, B. Burkitt lymphoma, C. Mycosis fungoides, or D. Follicular lymphoma. This boy with a past medical history of EBV infection presents with intermittent vomiting and an unintentional 12-kilogram weight loss over 6 months. His vital signs are significant for mild hypotension with a blood pressure of 80/60. This suggests vomiting-induced dehydration. Dehydration is further supported by the findings of sunken eyes and decreased skin turgor on physical exam. The patient also has hepatosplenomegaly. Stool culture, ova, and parasite tests and fecal fat studies are negative, making infection and malabsorption unlikely. The abdominal ultrasound reveals a hypoechoic mass in the duodenal wall. Biopsy of the mass shows small basophilic cells and evenly dispersed macrophages, leading to a starry sky appearance. These findings in a patient with previous Epstein-Barr virus infection are classic for Burkitt lymphoma. Let's recall that Burkitt lymphoma can occur in the jaw as well as abdomen. Burkitt lymphoma of the jaw is more common in African patients, while that of abdomen is more prevalent in the United States. So the correct answer is option B. Here's a slide reminding us of the types of non-Hodgkin lymphoma, including Burkitt lymphoma. Let's discuss why other options are incorrect. Option A is incorrect because Hodgkin lymphoma is characterized by binuclear Reed-Sternberg cells, which are absent on this patient's biopsy. Option C is incorrect because mycosis fungoides is a T-cell lymphoma that commonly presents as an eczematous skin rash. Additionally, the nuclei of the lymphocyte have cribriform shape in mycosis fungoides. Finally, option D is incorrect because follicular lymphoma is characterized by follicular arrangement of lymphocytes rather than the starry sky appearance on the biopsy. And that concludes our lecture on lymphomas.